Lip. Lip. Oh, Lip. Lip. Krik-krik ah. Nak tanya ni, untuk yang besok, maksudnya pakai yang daripada kes yang scan ke macam mana? Buka mic.
Apa? Esok.
Yang untuk besok, Dr. Mosak besok. Long case, maksudnya present daripada yang apa tu, yang Allah masalah. Yang daripada kes yang dia hantar ke?
Tak, tu kalau kita nak kes. Dia bagi contoh je. Kalau kita nak cari sendiri kat internet pun boleh je. Tak semestinya dia kasih tu.
Okay, tapi maksudnya doktor nak yang complete case lah daripada physical examination semua tu. Kau macam mana?
Sebab aku tanya doktor, dia cakap present long case macam biasa. Aku ingat lah ambil case write up lah. Yang lepas-lepas.
Case write up lah.
Yang sini lepas.
Tapi dia nak 2 orang kan? Siapa nak present?
Tak, orang lain. Ke kau nak buat randomizer?
Buat randomizer lah.
Buat lah. Kau buat lah.
Aku tak hati guna randomizer tu.
Okey, aku buat.
Alright.
Yang lain okey tak? Yang lain?
Sekali randomizer dapat kat aku nama first mati.
Tak kisah mana-mana. Sekejap ni aku share screenshot Dr. Mosak.
Kalau minta daripada grup-grup lain yang kelab boleh tak? Boleh kan?
Maksudnya? Oh.
Faham tak? Dia orang ada macam grup Taufik kan bagi suruh kelab patient kan?
Call. Maksudnya kita minta history dia orang memang 3 sebiji lah.
Macam tu je kan? Boleh kan?
Boleh kot.
Doktor nak kes je kan?
Nak kes. Tak kisah kes apa. Tanya dia present long case macam biasa. Pelik tak?
Ini dah record kan?
Dah.
Ada kau.
Halo, Assalamualaikum. Dengar tak?
Dengar.
Can you all hear me?
Yes, Doctor, yes. You can hear. Okay.
Hello, Assalamualaikum.
Doktor. Waalaikumsalam.
Waalaikumsalam.
Can you hear me?
Yes.
All right.
Yes.
Okay, good. Okay, so is everyone here?
One more person, Najmi.
Oh.
Okay.
It's okay, I will contact him.
Okay, why don't you just contact him and we'll just make a start. Right. So I thought what we're going to do today is let's just do some simulated history taking. So one of you can take a history from me, and then afterwards we can do some communication stations or communication kind of practice. So this is just in preparation for your OSCE when you come back. Who knows when? But I think regardless of the examination, I think communication is quite an important aspect of being a doctor. So I think it's I think it will be a good idea to kind of do some practice on that. So but first comes first. So we'll do some history taking, clerking. Whose turn is it to kind of do the long case discussion? Anyone?
We haven't discussed about the turn. Doctor just speak
Okay.
anyone at a
Just pick anyone, eh? Okay. Right. This is, let me just see the list of participants. Are these all in the same group or do we have outsiders as well?
we have two outsiders, Lina and
Okay.
Zati.
Okay, so I'll leave Lina and Zati alone. So let's just do, why don't we, I assume all the internet connection is okay. Let's go for Nur Salwa. Just because your name is in green, the rest is pink and blue.
Yes,
so
doctor.
Okay, is it okay if is your internet connection okay? Looks okay.
Inshallah, okay.
Inshallah, okay. Okay, let's just do some history taking. So what system do you want to do?
What system?
Respiratory, cardiovascular, neuro, GI.
Respiratory.
Respiratory. Okay. Is it because you think respiratory is easy or
No.
no? Okay, okay, fine. Okay, we can do respiratory. What system did we discuss last time? I can't remember.
Neuron. Apa?
What do we do? AGN, renal artery stenosis.
Yes.
Dia come with seizure.
Came with seizure. Okay, fine. Okay, good. So let's do respiratory then. Okay, let me think about a case. Okay, why don't we discuss this case? Okay, so okay, I'm the dad. So say I have a son who's currently 6 years old. Okay, he has a background history of failure to thrive. So he only weighs, say, 18 kilograms. 18, which are reasonable actually for 6. Okay, let's go for 15 kilogram. Right? So this boy, my son, who's 6 years old, weighs 15 kilograms. He has a background history of failure to thrive. And he came in with a history of productive cough. Okay, over to you. Who was it? Alia, was it? Sorry.
Salwa.
No, Salwa.
So the patient come with a productive cough. So I would like to ask about the duration.
Okay, so why don't you take a history? I'm the father. Okay. So why don't you take a history directly from me?
Okay, anak encik dah berapa lama dah batuk?
Okay, dia beratuk sebenarnya dah seminggu lebih dah sebenarnya.
Seminggu lebih. keluar kahak ke bila batuk tu?
Dia keluar kahak.
Keluar kahak warna apa?
Dia macam kuning-kuning, kadang ada juga masa dia hijau-hijau sikit.
Ada darah ke? Ada tak?
Darah tak ada.
Dia ada demam ke?
Demam minggu lepas ada sekejap. Dalam 2 hari macam tu lah demam.
2 hari. Sekarang dah okey dah?
Sekarang demam dia dah tak ada lah.
Dah. Dia dalam ahli keluarga tu ada yang batuk juga ke?
Dan keluarga setakat ni dia ada adik seorang 4 tahun. Adik dia masa tu ada sesama je lah batuk sikit-sikit. Dia yang start dululah. Baru abang dia ni kena. Tapi adik dia dah baik dah.
Batuk dia tu ada bunyi macam lain sikit tak? Macam
Dia bunyi dia macam batuk berkahak lah. Rasa
batuk berkahak.
macam ada kahak dalam apa? Dalam tekak dia lah. So setiap kali dia batuk memang berbunyi sikit lah.
Tak ada bunyi macam anjing menyalak ke? Ada ke?
Anjingnya lah. Tak ada. Mana batuk dia macam biasa, cuma dia bunyi macam berkahak je.
Oh, okey. Dia ada sesama jugalah.
Sesama tak ada sangat sebenarnya. Adik dia masa kena tu ada sesama, tapi dia tak ada sangat, dia terus batuk.
Dia ada sesak nafas tak? Nampak nafas dia laju?
Nafas dia memang setiap kali dia kalau batuk macam ni memang dia nafas dia laju sikit lah, saya perasan. Sebab tu saya macam risau. Saya bawa dia pergi kecemasan hari ni sebab nafas dia nampak tak berapa cantik.
Memang setiap kali batuk lah. Selama seminggu tu nafas dia laju.
Ya. Dia maknanya awal-awal tu tak laju sangat. Dia baru 2 hari kebelakangan ni lah saya perasan nafas dia macam lain macam sikit.
Dia ada mengadu cakap sakit dada tak?
Sakit dada, dia tak komplain, dia jenis tak komplain sangat. Cuma nampaklah bila dia nafas tu nampak dia tak selesa dah. Dia kena tarik nafas dalam-dalam kadang-kadang.
Dia tak ada cakap sakit kat mana-mana, tak ada?
Tak ada pula. Tak ada pula.
Dia ada sakit tekak ke?
Tak ada. Dia tak mengadu pun.
Selain tu, dia ada muntah-muntah ke?
Muntah kahak je lah. Kadang-kadang bila batuk dia teruk sangat, dia muntah lah kahak dia.
Dia muntah kahak. Yang batuk tu, dia punya selalunya berlaku waktu bila? Macam waktu pagi ke, waktu malam ke?
Dia macam sepanjang masa, tak tentu. Siang pun ya. Malam-malam pun kadang-kadang dengar juga dia terjaga batuk-batuk.
Dia ada dia macam kalau dia macam aktiviti harian dia macam lasak tak?
Dia nampak letih sikit sekarang ni. Semenjak dia batuk tu, mula-mula tu dia okey lagi. Cuma semenjak nafas dia tak berapa ngam ni, dia nampaklah dia letih, dia macam tak nak main-main dah. Dia nak baring je. Dia kata dia pernah mengadu dia penat lah.
Benar. Dia ada cakap sakit kepala ke?
Sakit kepala tak ada.
Doctor, should I proceed with the systemic review?
It's up to you. Do you think you have enough information for the presenting complaint?
Doktor,
Yep.
dia ada berpeluh malam-malam tak?
Yang untuk seminggu ni ke? Seminggu ni macam tak ada sangat. Tak ada.
Tak ada. Dia ada jumpa mana pesakit yang ada TB ke atau ahli keluarga yang ada TB?
Dia setahu saya memang tak ada lah. Sebab masa PKP ni pun banyak duduk rumah. Cuma lepas PKP tu dah habis, adalah bawa dia pergi keluar pergi makan macam tu je lah. Tapi tak ada pula perasan ada siapa yang batuk-batuk ke apa, tak ada. Dia pun pakai face mask kalau keluar rumah. Cuma hari tu lepas 3 hari batuk tu, saya adalah bawa jumpa doktor dekat klinik. Doktor bagi antibiotik so dia dah 5 hari dah makan antibiotik tu bagi, tapi saya rasa dia macam tak baik-baik. Saya risau tu.
Dari segi selera makan dia okey ke?
Selera makan dia kurang sikit. Saya perasan seminggu ni memang dia tak nak makan langsung. Sikit sangat lah kalau nak makan pun.
Jadi selain tu dia ada sakit perut ke, cirit-birit ada tak? Tak ada.
Masa seminggu ni dia tak adalah. Dia sebenarnya dia cerit-berit ni dia dah lama daripada kecil dia kerap dia cerit. Maknanya dia kalau membuang tu dia memang jenis membuang najis saja, najis yang lembik. Dia daripada dulu je saya tak rasa saya tak panggil dia cerit lah, cuma dia memang jenis macam tu. Najis dia macam lembik, so saya anggap betul normal lah.
Normal lah. Tak ada darah ke? Tak adalah.
Darah tak ada.
Dia ada cakap sakit nak kencing ke? Ada masalah buang air kecil tak?
Buang air kecil tak ada. Maknanya dia tak ada masalah lah. Dia memang kalau buang air kecil tu
Tak ada
macam biasa.
kencing berdarah. Kencing berdarah
Tak ada.
pun tak ada.
Tak ada.
Masa saya nak proceed dengan birth history, masa mak dia mengandungkan dia ada masalah apa-apa ke?
Semengandung tak ada. Setahu saya tak ada.
Tak ada. Dia lahir cukup bulan tak?
Dia lahir cukup bulan.
Cukup bulan. Berapa
38,
minggu?
38 minggu tak silap.
38. Berat dia masa lahir berapa?
Berat dia, okey. Berat dia saya rasa dalam 3.1 macam tu lah. Lebih kurang.
31. Dia beranak normal ke? Lahir secara normal ke?
Normal lah.
Masa lahir tu ada apa-apa komplikasi tak?
Tak ada. Dia lahir, besoknya tu dah boleh discharge rumah dah. So memang tak ada apa-apa lah.
Dia ada penyakit kuning ke?
Kuning tak ada sangat.
Dia minum susu ibu ke masa kecil?
Dia
Ke
memang
susu botol?
susu ibu. Susu ibu
Susu ibu.
6 bulan, lepas 6 bulan baru tukar susu botol. Sebab mak dia masuk kerja balik.
Dia start makan waktu dah boleh makan tu umur 1 tahun lah. Boleh makan.
Sebenarnya dah 6 bulan tu dia dah makan bubur sikit-sikit macam tu lah. So
Dari
daripada
segi
tu
dari segi selera dia waktu dulu okey lah.
tu yang saya pelik tu dia ni sebenarnya dia makan saya rasa tak pernah ada masalah lah. Kalau bagi dia makan habislah satu pinggan. Dia jenis makan macam bagi saya macam biasa lah. Saya ada anak seorang lagi umur 10 tahun. Dia bagi saya dia makan lebih daripada abang dia. Tapi dia ni tak tahu berat badan dia kenapa tak naik-naik. Saya pun tak pastilah kenapa.
Dari segi pembesaran dia semua okey ke? Daripada dulu
Pembesaran
sampai
dari segi main dari segi apa tu? Dari segi berat badan ke macam mana?
dari segi bila dia boleh berjalan semua tu.
Oh, okey. Saya rasa tak pernah ada isu lah. Dia berjalan umur 1.5 tahun dia dah start jalan.
Semuanya
Plan
okey lah, normal lah. Macam tak lambat.
semua. Tak, bagi saya tak lambat lah. Sama lah macam abang dia dulu.
Sekarang ni berat dia 15 kilo kan?
Ya.
Start bila yang dia ada berat badan dia tu tak cukup tu?
Saya sebenarnya tak perasan sebenarnya. Nampaklah dia macam kecil sikit daripada abang dia dulu. Saya ingat dia macam biasa dah budak-budak kan. Mungkin dia lambat sikit nak membesar. Tapi bila saya hantar dia ke sekolah, prasekolah baru saya perasan. Dia ni macam kecil sikit lah daripada anak-anak lain kan. So, dan pernah lah doktor sebelum ni masa dia kecil-kecil dulu, masa kat KK timbang badan dia semua pernah lah dia. Orang tanya kenapa berat badan dia tak tinggi sangat. So saya ceritalah saya dah bagi makan semua. Lepas tu diorang masa tu rasa nak refer dietitian dietitian, jumpa sekali dia adalah suggest untuk tambah susu. Lepas tu saya terlupa nak follow up. Tak jumpa balik. Lepas tu.
Sekarang tinggi dia berapa?
Tinggi dia berapa rasa sekejap I have to think. Dalam 80 cm kot. Betul ke 80 cm logik tak? Boleh lah 80 cm. Dia pendek. Kalau ikut sental tu, doktor pernah cakap dia kurang daripada sental ketiga, betul ke?
Oh. Okay.
Itu apa yang doktor pernah sebut lah yang saya ingat.
Dia ada sakit apa-apa ke sebelum ni?
Dia ni nak ikutkan dia memang jenis yang banyak kali juga masuk hospital. So macam dia batuk ni bukan yang kali pertama lah sebenarnya. Dia dah kerap dah batuk-batuk.
Oh, dah banyak kali lah.
Ya.
Dia pernah dapat oksigen ke sebab sesak nafas?
Dia memang kerap sekali kalau dia batuk, doktor akan cakap dia ada jangkitan paru-paru. Dia akan bagilah antibiotik, oksigen. Memang kerap lah.
Kalau dalam sebulan tu berapa kali dia jadi macam tu?
Nak kata sebulan sekali, tak juga, dia tak tentu. Ada macam tahun lepas, 2019 kan, tahun lepas ada lah dalam 5-6 kali warded. Tahun
Masa
ni,
2019.
macam mana?
Kiranya setahun tu dalam 5-6 kali lah.
5-6 kali warded. Tahun ni pun ni dah kali keempat dah warded.
Memang simptom dia tu sama je lah. Batuk, sesak
Dia
nafas.
setiap kali tu doktor cakap memang ada jangkitan paru-paru. Dia kata dia tengok x-ray dia, tak tahulah kan. Saya pun tak pernah nampak. Tapi dia kata x-ray dia mesti ada macam kesan putih-putih, kesan jangkitan. So memang macam tu lah cerita dia. Setiap kali masuk, saya pun dah agak ni sebenarnya. Sebab tu saya, masa dia demam baru-baru ni dengan batuk, saya dah bawa dia jumpa doktor cepat-cepat minta antibiotik. Cuma kali ni itulah nampak macam tak jalan. Sebelum ni macam tu juga, kadang-kadang jumpa klinik bagi antibiotik memang tak jalan. So nak tak nak kena bagi apa, doktor kata kena bagi antibiotik yang cocok, yang kuat sikit kan. Baru dia okey.
Dia ada alergi apa-apa ke? Alergi makanan ke?
Setahu saya tak ada.
Tak ada. Dia ada eczema ke? Ada tak? Macam
Eczema,
kata-kata.
kata tak ada.
Tak ada. Macam sedung ke selalu bersin pagi-pagi?
Resdung tak ada. Dia bukan jenis yang macam resdung kan. Orang kata asma. Dia macam bukan asma lah. Sebab dia tak ada resdung. Dia sekali dia masuk hospital pun dia tak ada lah macam kena pakai nap kan, macam asma kan. So dia bukan jenis yang tu.
Dia ada ambil ubat apa-apa tak? Macam on medication ke?
Ubat yang baru-baru ni antibiotik lah yang doktor bagi, ubat demam.
Antibiotik lah. Ubat tu berkesan ke kat dia? Ke nampak sama je?
Saya nampak macam lagi teruk dia.
Lagi teruk. Ubat apa
Yang mana antibiotik tu Saya tak tahu pula nama apa. Dia warna pink. Warna putih.
Ayah ni umur berapa?
Saya 42 sekarang ni.
42. Mak dia?
Mak dia dah 38.
Mak ayah dia sihat ke ada sakit apa-apa?
Saya alhamdulillah sampai sekarang tak pernah ada problem lah.
Mak dia?
Mak dia dulu, setahu saya masa kecil-kecil dulu dia ada asma, tapi masa kecil lah. Dia rasanya bila dia dah besar tu tak ada langsung lah sebenarnya.
Saya nak tanya, kalau masa dekat rumah tu ada bela kucing ke? Ada ke?
Kucing tak ada.
Tak ada.
Anak saya ni pun kalau main kucing kat kampung, kadang balik kampung dia main kucing. Dia suka kucing. Memang tak ada pun batuk-batuk sesama lepas tu, tak ada lah.
Dia kalau dia macam buat aktiviti lasak, dia macam cepat penat tak? Dia macam ada hype.
Dia nak kata kalau dia sihat, dia sebenarnya tak ada halangan. Dia boleh lari, bersukan. Dia waktu bila dia kena batuk, time tu memang dia nampak penat.
Nampak
Time
penat.
tu dia memang dia tak nak beraktiviti lah. Tapi hari-hari yang dia okey, dia boleh lah nak join aktiviti sukan, PJK.
Dia pernah tak macam tak dapat pergi sekolah sebab batuk, macam penat sangat ke?
Dia kerap juga miss sekolah. Sekali kalau dia warded pun bukan sehari dua. Dia kadang-kadang seminggu, 2 minggu pun ada.
Oh, lama
Setiap kali
lah.
dia warded. So dia memang kerap miss dia punya sekolah dia.
Kalau masa setahun tu berapa kali yang warded tu?
Itulah macam tahun lepas dah 6 kali, tahun ni kali keempat lah.
Berapa kali dia kena warded? 4 lah.
Sekali,
Selalunya doktor bagi treatment apa kalau dekat hospital?
dia bahkan bagi itulah oksigen dengan antibiotik yang ikut cucuk, ikut jarum.
Sebab
Kadang,
jangkitan paru-paru.
ya, itu yang doktor sebut lah. Saya pernah tanya juga doktor, ni asma ke? Tapi doktor kata bunyi macam bukan asma kan. Sebab kalau asma, diorang pakai yang pump tu kan. Doktor tak ada pula bagi yang pump ke apa. Okay,
Tak tahu
nak tanya apa-apa lagi?
Tak tahulah. Kita tanya orang lain pula.
Yeah, okay. Anyone else wants to ask anything?
Okay. Tak apa.
Sila.
Doktor nak tanya pasal immunization okey ke?
Memang lengkap. Tak pernah miss lah.
Lepas tu nak tanya, dia ada hilang berat badan tak? Turun berat badan?
Dia
berat tak naik je?
Dia berat tak naik je. Dia nak kata hilang, tak juga. Kalau ikut graf tu, dia naik lah sikit-sikit. Graf apa yang berat badan tu kan. Cuma dia kecil lah. Dia memang, kan graf tu dia macam ada line banyak-banyak kan. Dia memang tak masuk line langsung lah. Dia kat bawah sekali.
Okay. Lepas tu
memang daripada dulu macam tu lah.
Dia ada suara dia ada jadi serak ke? Ada perubahan suara tak?
Tak ada.
Tak ada. Dia ada susah nak telan ke?
Susah telan tak ada.
Okey. Sambah sila.
Okay. Tadi berkenaan dengan batuk tadi.
Siapa
Tadi
nama?
kawan
Sambah?
Saya. Tadi kawan saya.
Itu nama panggilan ke betul?
Nama saya.
Oh ya? Yeah?
Muhammad Mustafa Sambah.
Oh, okay. Sorry, sir. Okay. Sorry kejap.
Okay, tadi berkenaan dengan batuk, kalau saya ada tanya sedikit berkenaan batuk dah seminggu, lebih kurang seminggu. Jadi dan tadi Encik kata batuk tu ada kadang-kadang kahak keluar kuning dan hijau kan? Betul kan?
Ya, betul.
Jadi saya nak tanya, macam mana progres kahak tu? Maksudnya, adakah dia batuk tak ada kahak, lepas tu jadi kahak sikit-sikit, jadi ada keluar kahak banyak ke atau macam mana?
Dia, saya perasan kahak dia, kalau dia macam ni, setiap kali saya perasan, sebab benda ni dah kerap sangat berlaku. Awal-awal tu kahak dia macam jenis cair kan. Lepas tu tapi lama-lama dia akan jadi pekat lah. Dia akan jadi pekat. Lepas tu bila dia pekat tu, time tu dia akan struggle lah dengan bernafas dia.
Okey. Itu dari segi keberkatan, dari segi warnanya, maksudnya dari warnanya
Warna pun memang dia akan, itulah dia akan makin lama makin nampaklah kuning, kadang-kadang hijau, makin lama makin pekat lah.
Okay. Dan lepas tu cakap kata tadi batuk ni dah seminggu dan kadang-kadang waktu pagi, waktu malam tak tentu kan dari segi masa. Tapi kalau sekali dia datang batuk tu, adakah batuk tu lama dalam 10 minit macam tu ke atau sekejap-sekejap batuk?
Dia kalau setiap kali datang batuk tu memang berterusan lah.
Berterusan.
Dia tak ada waktu-waktu dia akan hilang. Maknanya kalau seminggu tu memang nampak ada progression lah, makin teruk lah. Batuk dia makin kerap, kahak dia makin pekat.
Okay. Tapi kan batuk tu lama kan. Maksudnya kalau sekali datang batuk, macam mana dia stop tiba-tiba hilang batuk tu? Adakah dia ada ambil apa-apa atau memang dia hilang sendiri? Faham tak maksud saya? Macam dia batuk lama, betul berhenti kejap, batuk balik kan? Apa yang stop dia sekejap tu? Ke dia tak ada buat apa?
Saya pernah agak try bagi ubat batuk tapi tak pernah jalan lah. Dia kalau stop pun lepas dia keluarkan kahak, nampaklah dia lega sikit.
Okay. Lepas keluar kahak tu lah.
Okay.
Doktor, saya nak tanya.
Yep.
Pasal kahak tu kan, kahak tu berbau tak?
Berbau? Saya tak adalah terfikir nak bau, tapi saya tak perasan lah sebenarnya kalau ada bau kuat ke apa.
Okay.
Encik,
Ya.
Masa dia bernafas kan, ada berbunyi tak?
Bernafas tak, dia bunyi kahak je lah.
Okay. Lepas tu selama pernah masuk hospital ni kan, pernah tak anak encik undergo pembedahan, mana-mana pembedahan tu?
Pembedahan tak ada.
Okay. Itu je lah.
Dia kalau masuk hospital tu memang sebab paru-paru je masalah dia.
Okay.
Encik nak tanya, pasal kahak yang keluar tu, agak-agak banyak mana? Dalam satu sudu besar ke, sudu kecil ke?
Okay. Dia itulah nak cakap memang banyak jugalah. Bolehlah katakan setiap kali keluar tu, dasar cawan tu penuh lah.
Ya, sekali.
Setiap
kali batuk lah.
Sekali batuk memang
batuk.
Banyak tu lah. Tapi nak kata dalam sehari tu mungkin adalah dalam 5-6 kali lah dia akan keluar kahak macam tu.
Lepas tu encik cakap yang tahun lepas pun dah 5-6 kali kan warded kan. So nak tanya, bila yang dia kali pertama masuk ward sebab jangkitan kuman paru-paru?
Okey, mana daripada kecil ke? Daripada kecil. Saya perasan sebenarnya umur dia sebelum dia umur 2 tahun. Mana 2016. Dia lahir 2014. 2016 masa umur dia 2 tahun. Dia kena.
Itu kali pertama lah.
Itu kali pertama, mula-mula tu okey lagi. Lepas setahun kemudian tu baru saya perasan dia makin menjadi-jadi lah. Maksudnya first time tu dia kena umur 2 tahun, warded sekali. Tahun berikutnya 2-3 kali. Lepas tu tahun lepas tu sama juga macam 2-3 kali. Tahun lepas yang paling banyak lah.
Betul.
Tapi saya ingat masa tu dia banyak mungkin sebab dia dah masuk sekolah kan, dia bercampur dengan anak lain, so sebab saya anggap itu punca dia lah masa tu.
Doktor, anak encik tak pernah masuk ICU ke disebabkan hal ni?
ICU actually dia pernah masuk ICU tahun lepas. Tapi dia tak adalah sampai tak sedar tak, tapi masa tu doktor risau tengok nafas dia laju sangat. So dia nak monitor dengan rapi lah masa tu. So dia masuklah ICU sekejap dalam sehari dua macam tu. Tapi sekadar monitoring lah. Dia bagilah macam oksigen. Lepas tu ada kot bagi nap sikit-sikit sekadar nak tolong nafas dia sikit. Lepas tu saya ingat dia pakai CPAP masa tu ada ke?
Ada.
Istilah CPAP saya pun tak faham sangat istilah doktor ni. So dia pakai dalam sehari dua, lepas tu dia masuk ward biasa lah. Lepas tu sekali tu je lah saya ingat tahun lepas. Awal tahun lepas.
Okay.
Tahun ni tak ada lagi.
Doktor, baru-baru dalam kebiakannya ni sejak dia sebatuk, dia ada macam selalu tidur tak? Letih selalu tidur tak?
Dia memang letih lah. So, setiap kali macam dia akan terbaring. Dia macam tak bermaya lah.
Okay.
Okay, anything else? Before
Doktor?
we go for physical exam? Yeah.
Nak tanya pasal yang ayah dia refuse, terlupa nak follow up dengan dietitian tu. Tahun bila?
Yeah.
Tahun
Dietitian
bila
tu
ada?
lama dah sebenarnya. Rasa umur 2-3 tahun macam tu lah. Tak silap saya. Yang doktor perasan lah dia nampak macam tak berapa cantik. Lepas tu itulah saya pun silap saya juga sebab saya busy. Saya kerja offshore. So tu yang selalu miss appointment dia. So sejak itu saya tak terfikir nak call balik dietitian tu.
Okey, kiranya tahun ni hospital tak refer balik ke dietitian ke ataupun memang dah tutup kes yang nak refer ke dietitian?
Tahun ni dorang ada juga cadang nak refer tapi tak tahu tak dapat appointment lagi ke macam mana ke. Itulah saya ingat kali ni boleh lah nak minta doktor refer balik lah kot.
Okey, thank you doktor.
Satu lagi Encik, kan setiap kali admit masuk ward tu, Encik ada cakap yang doktor kasih antibiotik dan juga oksigen kan. Lepas tu ada perasan ke ada grup fisioterapi yang ajar cara anak Encik bernafas dengan betul ke?
Ada juga.
Ada
Fisio
juga
ni
lah.
yang tepuk-tepuk dada tu kan?
Yang tepuk-tepuk dada.
Ada juga.
Setiap kali admit ward lah.
Boleh katakan setiap kali.
Okay.
Okay. Alright, good. Physical exam. Okay, going back to Nur Salwa tadi. Okay, what do you want to know in your physical exam? Tell me what you want to know and I'll tell you what the finding is.
From general.
General appearance. Okay, general appearance, he looks cachectic, very malnourished.
Okay.
Nak kata malnourished. He looks very cachectic lah.
Okay.
Yeah, he looks like he doesn't have any fat tissue.
For the hydration status?
Hydration status is actually good. Mucous membranes are moist. Good skin turgor. CRT is less than 2 seconds.
Okay. For endotrachea is centrally located.
Trachea is centrally located. Yeah.
For the chest expansion?
Chest expansion is equal bilaterally.
On percussion? Is it?
On percussion, dull on the right base. The rest is pretty resonant.
On auscultation?
Okay, what do you want to know on auscultation?
I want to know if there is a fine crepitation.
So you want to know added sound. So added sound, yeah, there is some fine creps on the right side and a little bit of fine creps on the left side as well.
For the air entry?
Air entry, okay, good. Air entry is reduced on the right side, on the right base. The rest is acceptable.
Is it the normal type of breathing?
So he's normal. Define normal.
Vesicular breath.
Vesicular breath sound.
Oh, okay. So it's vesicular breath sounds, yeah, throughout. Okay, lagi. What else do you want to know?
Is there any swelling at the leg, at the limbs?
Swelling tak ada. No edema.
At the lymph node?
Lymph node, there's a few small shorty lymph node on cervical area. But they're not really large. They're mobile and they're non-tender. Okay, lagi? Just imagine this 6-year-old in front of you. What other aspects do you want to examine him?
The development?
Okay, development normal. GCS is full. Anything else in relation to respiratory exam that you want to know?
Is there any clubbing, finger clubbing?
Yeah. Okay, so clubbing is present.
What grade, doctor? Grade?
I would say maybe grade 3.
Grade 3. Okay. Is there any cyanosis? No.
No cyanosis.
For the pulse, the vital sign?
Vital signs, okay, pulse is 128.
The respiratory rate?
Respiratory rate is 40.
The temperature?
Temperature is 37.6.
The blood pressure?
Blood pressure is 98/70.
Is it the patient looks in pain?
In pain? He looks he looks comfortable. I mean, he doesn't look like he's in pain, but he looks tachypneic.
Is it he on any oxygen?
Yes, he's on 2 liters of oxygen via nasal prong. Okay, what else do you want to know in relation to oxygen?
The attachment, is it he is on medication?
I mean, no other medication currently. What other parameters do you want to know in relation to oxygen?
I don't know, doctor.
How do you measure whether a person is receiving enough oxygen or not. What parameter do we use? Okay, Samba was just showing his finger just now.
Pulse oximetry.
Pulse oximetry, yes. So what we want to know there, SpO2 kan? Pulse oximetry is the technique, okay? The name of the technique to get the SpO2. So his SpO2 is 92%. Okay. Any other physical examination components that you want to perform?
I don't know, doctor. You can ask other people, other persons.
Okay. Okay. And anyone else wants to know anything about the physical examination?
Doctor, is there any chest deformity?
He's got pectus excavatum that you can clearly see. And there is also some presence of Harrison sulcus. Okay, lagi?
Doctor, for abdominal examination, is there any signs of the chronic liver disease, such as?
He does have, so his liver size is about 3 centimeters below the right costal margin. So to some extent, he's got mild hepatomegaly.
So for abdominal examination, only hepatomegaly, which is abnormal. Everything.
Yeah.
Okay. So for
the rest of the abdo exam is normal limits.
So for ENT examination, specifically for the nose, is there any nasal polyps?
Nasal polyps tak ada.
Any ear discharge?
Ear discharge pun tak ada. Okay, anything else you want to know?
Just now on periphery, there's no peripheral cyanosis. Means on the central, there's no central cyanosis also?
Yeah, no cyanosis, either centrally or peripherally.
Okay, how about the cardiovascular examination? Is there any murmur or any added heart sound to the heart?
Okay, so it's a normal S1 and S2 is heard, no added sound. Okay,
Apex
there's
B
no
is
gallop. Apex B is in the 5th intercostal space. There's no gallop rhythm. Yeah, no murmurs. JVP is normal. Okay, lagi? Okay, anything? Anyone? Tak ada? You guys happy with all the information so far? Okay, so no, Sawa, can you just briefly summarize only the positive history and physical exam? What did you manage to get?
6-year-old boy.
Yeah.
Who has a history of failure to thrive.
Yes.
Come to hospital due to productive cough for 1 week duration.
Yeah.
And also he also have shortness, rapid breathing.
Yeah.
Mm,
Yang lagi?
okay. Sorry, doctor. And then should I tell about the cough, the characteristic?
No. Okay. Yeah, you can do.
Okay. So the boy have a productive cough for 1 week duration, and the sputum is a yellowish, and there is no blood.
Yeah.
And he also have a history of hospitalization
Yeah.
about 4 to 5 times per year.
Yeah.
And he also has a history of lung infection.
Yeah.
And then
History. What about the lung? What about the lung infection history? Is it significant?
I think yes.
Why?
Why? Because mm, it may be related to the disease that he has now.
Okay.
Okay.
Yeah.
And then he also has her mother also has asthma. Has a history of asthma.
Is the mom's asthma significant, you think?
I think no.
Okay, why not?
Because
You're right.
Because the child has not has no atopy.
Okay, there's
Such
no
as
other history of atopy in the child. Do you think what about the mom's asthma? Is it something that carries a risk factor, significant risk factor? What about the asthma in a mom that I mentioned?
only the mom only has asthma during young age.
Childhood asthma, yeah. So
Childhood
childhood
asthma.
asthma, it can be a risk factor in certain asthma cases, but I mean it's not as significant compared to if the parents still has asthma when they're older. So that's more significant. Okay, good. Anything else?
And then and he also always look lethargy. And on the physical examination, he looks very cachectic.
Yep.
And malnourished, and
Yep.
there is a pectus excavatum on the chest, and then there is Harrison sulci, and on the abdominal
What
access.
is the significance of that? What does that indicate if you have presence of all these chest deformity?
He been in respiratory distress for a very long time.
So if we could have had recurrent episodes of respiratory distress and lung insult, and okay, so that is a sign that this child has had. Sometimes, yeah, you do get a history, some from parents yang say, oh, memang setahun 5-6 kali doktor admit masuk ward. But this could be just your standard recurrent viral URTI, and when you assess the child looks well built, there's no chest deformity, and that kind of supports your thinking that the previous admissions was probably minor chest infections that are not that significant. But if you have a history like this, recurrent history, and then you look at the child, he looks cachectic, there's some chest deformity, so that means he's truly got a significant lung pathology, and so it's a useful sign to actually detect. Okay, lagi. What else about the physical exam?
There is a hepatomegaly.
Okay, lagi.
I think that's all.
Okay. Any else has clubbing kan? You mentioned that, forgot. So he has clubbing grade 3 and okay, so that again might indicate what? What's the significance of the clubbing?
It might suggest a chronic condition.
Yeah, so I mean, clubbing is a sign of chronic condition. It can be respiratory, cardiac, or to some extent liver. And so our cardiac, we know that this child doesn't have much cardiac signs, right? So no murmur, no cyanosis, no displaced apex beat, and doesn't look like the child's in failure, apart from slight hepatomegaly, which we can, which we can ignore for a while because it's not that significant. Okay, so yeah.
Can it be cystic fibrosis?
Yeah. Okay. Why can it be cystic fibrosis? What supports the diagnosis so far?
Because there is a clubbing, recurrent productive cough. Yeah, that's my suggestion. I don't know.
Okay. Any other differential diagnosis it could be so far? Since you mentioned you offered possible diagnosis. Any other differentials?
Tuberculosis.
TB, okay. TB, I think it's worthwhile excluding, definitely. Yes, especially if there's an underlying TB that's been there for a long time. But if you understand about TB, it's a chronic condition, but it's a slowly progressive condition. Right? So if it's not treated, the child should get worse. Whereas the history of this child is a little bit different. He has moments of wellness. Yeah. So he has symptoms of getting infection like this, followed by symptom-free episodes where he can still exercise and do things, which is unlike TB. TB, it should be slowly progressive, slowly getting worse, along with other symptoms such as your night sweats. And TB, you get weight loss. Yeah. So weight loss, so the child is normally very healthy, well-built, good weight, and then suddenly lost weight. So the history of this child is a bit different. This is failure to thrive. This is not weight loss we're talking about. So you have to understand the difference. So weight loss and failure to thrive are two completely different pathological entities. So one of them is causing them to lose weight from, say, acute infection and whatnot. The other one is failure to gain weight because maybe there might be problems of inadequate intake, failure to absorb the nutrients, or they are losing the excessive loss of the nutrients, so they couldn't really store it. Yeah, so you have to look at it in that angle. So in this child, there's no weight loss, there's failure to thrive. Okay, so yeah, but I can accept TB as a potential differential. Okay, lagi? Any other differential diagnosis?
Doctor, for the cystic fibrosis, I've read that it is a disease that will cause viscosity of the secretion, including the exocrine gland. So there will be pancreatic insufficiency. So it will lead to maldigestion, malabsorption, and malnutrition. So the stat will have failure to thrive.
Yes. Okay. Good. So what are any other symptoms that supports pancreatic insufficiency in this child? What are the symptoms do you expect to get if you have insufficient pancreas?
Steatorrhea.
Steatorrhea. Okay. So how does a steatorrhea present? What is steatorrhea?
The I do not know how to explain.
What is steatorrhea? What do you expect? How would the patient complain if the patient has steatorrhea?
Najis dia sentiasa lembek.
Yeah, so it's very greasy, soft stools, and that is foul smelling. Usually busuk. Okay, why is that? What's the pathogenesis that's happening here?
Malabsorption of fat.
Malabsorption of fat. So the fat cannot be absorbed. Why?
Because there is no production of the lipase.
Yeah, so you don't have the lipase enzymes to digest the fat and absorb it in the first place. And lipase is part of the exocrine function of the pancreas. So that's the exocrine. What's the endocrine function of the pancreas? Can you think of any? Huh?
Yeah, insulin dengan glucagon.
Right. Insulin. Insulin production what cells from the pancreas that produces insulin?
Pancreatic islets.
Pancreatic islet. What type cell? What type of cells?
B cell.
B cell.
B cells, right? Or beta cells, beta cells of the pancreas produces the endocrine functions, including your insulin. Okay, so if you lack of insulin, what symptoms might you get? If your body cannot produce insulin because of pancreatic insufficiency, what symptoms can you get? Yeah. Apa? If you don't have insulin in your body, what will happen to you?
Diabetic.
You get diabetes, and so you cannot, you cannot absorb your glucose.
Yes.
So you become hyperglycemic. Hence, you get diabetic signs and symptoms, including
often urinate.
Okay.
Frequent urination.
Yeah, polyuria, increased frequency, polydipsia, increased thirst, right? Okay, I mean, in this child, those symptoms are not there, okay? But it's still something to think about, okay? In view of this child, ada history of loose stools and ongoing on and off loose stool. In CF, they can have alternate loose stool from the steatorrhea, and sometimes they can get constipation from the sticky stools as well. So because the secretions from the gut is also sticky. So sometimes they can have alternate symptoms of constipation and steatorrhea intermittently. Okay, any other differential diagnosis? We mentioned CF, TB. We don't think this is asthma. Do you think this is asthma? Could this be asthma? I mean, I wouldn't rule out asthma completely because it's so frequent and it's one of the most frequent cause of recurrent chest infection and exacerbation. I wouldn't rule it out, but the risk the risk factors are not really there. So if you think about the
API.
The API index and whatnot, although this child is older now, there's no strong family history of asthma or hay fever. The child himself doesn't have any atopy, right? And there's hardly any recurrent use of nebulizers, or the child himself is not on any MDI. So again, the history doesn't sound like asthma, but you can never say for sure, until you do the spirometry, which is the gold standard test. Okay, right. Okay, so any other differential?
Bronchiectasis.
Bronchiectasis, yeah, I think is a good differential. I mean, but bronchiectasis is a very broad diagnosis because it can be caused by many other different pathologies. Even CF can lead to bronchiectasis, but you can also get bronchiectasis from other non-CF conditions, such as primary ciliary dyskinesia, such as recurrent aspiration. For example, if we have very severe reflux that's not treated, if you get recurrent aspiration and infection, that can cause suppurative lung disease. So bronchiectasis is just a form of suppurative lung disease that has caused irreversible damage to the lung architecture. So that causes massive dilatation of the airways because all the lung tissues have died out. They have necrosis, leading to a lot of areas where you get your alveoli damage, and that creates a lot of dilatation. So the typical finding of bronchiectasis is on a CT scan. You get these multiple dilated airways and signifying tissue damage from recurrent infections. Okay, bronchiectasis can also be caused by immune problems, such as your primary immunodeficiency, your PID's conditions. For example, if you're deficient in T4 or T2 or whatnot, that can lead to recurrent chest infections leading to bronchiectasis. So I accept bronchiectasis as a differential diagnosis, but I wouldn't say it's a complete differential just because it depends on what causes bronchiectasis in the first place. And sometimes we do have situations where we don't even know. I mean, you have changes on the CT scan to suggest bronchiectasis, but when you look at other tests and you take the history, you cannot really find out the cause behind the bronchiectasis. And sometimes we do have patients like that. Yeah, okay, good. So I mentioned other possible differential, such as recurrent aspiration in case of severe reflux. So this is a GI. So again, you remember I was saying, when it comes to differential diagnosis, think about the component, the systems involved, cardiac, respiratory, GI, and whatnot. So cardiac we've not mentioned. Cardiac, if the child has congenital heart disease, can also lead to recurrent chest infection, because whenever you have signs of heart failure, and your body has to work harder, and sometimes you can get some degree of immune problem secondary to cardiac, long-term cardiac cause, and that can lead to recurrent chest infection as well. So I don't think we can rule out cardiac completely in this case as well, although clinically there's no finding yet. So we covered immunity, GI in terms of reflux disease. So you really had to look at all those aspects to kind of formulate your investigation or differential diagnosis, and then your subsequent investigation tests that you want to perform. Okay. So what investigations would you do in this child? Salwa, are you here?
Yes, doctor.
Okay, what investigations you want to do, and I'll tell you what the finding is, the results are.
So first, I would like to do full blood count.
Okay, so HB is 10. White cell is 36, predominantly neutrophil 24. Platelets is 315. Okay.
And then I would like to do chest X-ray.
Okay, chest X-ray, he's got consolidation on the right lower zones. Okay, Lee. Any other investigations you would do?
Sweat test.
Okay, you want to consider a sweat test in view of the recurrent chest infection and failure to thrive. There's a history of clubbing. Okay, sweat test. It takes a while for that to come back. Any other investigations to perform at this stage?
Liver function test.
Good. Okay. So liver function test. EST is normal. The alkaline phosphatase is high at 1,000 something. The bilirubin is also high at around 60. INR, the clotting is normal. Okay, lagi. What else? Just any other routine investigations that you can do.
Renal profile.
Yeah, okay, so renal profile, sodium is 140, potassium is 4.9, chloride is 99, urea is 6, creatinine is 35. Okay, what else?
Fasting blood glucose.
Okay, so you want to do fasting blood glucose. So say it's about 5.5. Okay, anything else you want to do? So
I would.
So what have you found based on the blood test? What is the obvious problem that you can see? What is the thing that you've identified so far that you should be able to start some treatment already? Hmm? What is the diagnosis so far? I mean, forget about his underlying condition yet. Just what is the obvious diagnosis that you can see in front of you from your X-ray and your blood, full blood count so far, and so on?
It could be pneumonia.
Yeah, so he's got pneumonia clearly, and so he's got consolidation, raised white cells, and so he's got some active infection going on. So what are the tests to support that? You know, to support whether this is viral, bacterial, then you want to know that, and TB. So what other tests would you want to arrange?
Is it
Other tests?
blood
Sputum
culture?
culture.
Blood culture, yeah, okay. So I think I would send blood culture. Any other culture that would be useful?
Sputum culture.
Sputum culture. I mean, remember, he's got a productive cough, so it's quite easy to actually get some samples from him. So you're going to send for sputum culture, can? Okay, so that's pending. Blood culture you sent pending. And the other tests you want to do? Any markers of infection that might be useful? Yep. Any markers, infection markers?
Yes,
Apart from white cells? Yeah, CRP and ESR, procalcitonin, which is the one that's fairly new. And these are all useful parameters that you can send to know whether this is bacterial or not. And so usually if the CRP is very, very high, if the procalcitonin is very high, then you think more towards bacterial infection or TB. And okay, so I mentioned TB a few times. What tests can we do for TB?
Mental test.
Yeah, you can do simple tests like MON2 to begin with. If you want anything a bit more specific, you can do some gastric lavage, for 3 days in a row. Early morning gastric lavage might yield some cultures. The problem with mycobacteria, they are very difficult to sample, because they like to be in very deep structures. Sometimes it's very difficult to obtain. Even sputum culture might not yield any result. So you need sometimes, if the child is fortunate enough to swallow some of his sputum and it ends up in the stomach, you can do some gastric lavage on 3 days, on 3 consecutive days, to increase the chance of you getting the organism. But despite that, even gastric lavage is a very poor test to do because you can never get the organism that you want. So the next test would be what? What are the useful tests you can do? Can you do some blood tests?
Smear. Green staining.
Not quite smear. What testing can you do? You can do quantiferon, so, or ELISA. Have you heard of that? Yeah, so it's actually a DNA. You're looking for a DNA of the mycobacteria, that is probably in the bloodstream, or actually you can also do it from the sputum as well. So that's a much more more specific test that you can arrange, although it is expensive to some extent, but it's just a simple blood test, quantiferon TB, or QFT. This is the latest kind of gold standard test that we would do, especially in children, because children are far more difficult to expectorate and to get the right sample. MON2 test is useful in a way, but remember, MON2 test done in a child can be a reaction from the BCG. So a positive MON2 is never confirmation of TB. It raises, it's useful when it's negative. For example, if a negative MON2 is there, then that might mean that it's unlikely to be, but a positive MON2 doesn't confirm TB. You always need to recheck with the quantiferon or any other sampling test that you choose. Okay, all right. So you're done for blood count, chest X-ray. You check the electrolytes. You check for TB. You do some inflammatory markers, okay? So now you want to think about underlying conditions. So that's why some people were mentioning about sweat tests and whatnot. Any other tests, subsequent investigations you want to do to find out whether this has got any underlying condition that might explain his failure to thrive and recurrent chest infections? Okay, sweat test is one. What else you would consider?
Stool culture.
Stool culture, okay, because there's a history of malabsorption here. Fair enough. Okay, lagi. can you actually measure the amount of fat in your stool?
I'm not sure.
Yeah. So how can we measure what we can actually? So from the stool sample, how can we know whether there's pancreatic insufficiency or not? Do you know of any tests to do? Can you think of any? Enzyme?
Fecal lactase.
Fecal elastase. Well done, eh? So what is fecal elastase?
Yeah, I can remember. Read somewhere.
Okay, so fecal elastase is basically an enzyme produced by the pancreas, and so it's one of those lipase enzymes. So if you measure the fecal elastase and it's reduced, okay, to some extent, then you know that the pancreas is not producing enough. Okay, so that's a useful sign or test to do, isn't it? To support the notion of pancreatic insufficiency. In children, by far the most common cause of pancreatic insufficiency is CF. I hardly come across any other conditions actually. Isolated pancreatic insufficiency itu jarang sekali lah dengar. We come across a few children who are diabetic, but again, the exocrine function in a diabetic child tend to be normal. They can still be normal. It's just the endocrine component that, the destruction of the beta cells that have occurred in the type 1 diabetics. Okay, anything else about underlying condition? Think about the differential earlier. It can be cardiac, it can be GI, it can be immunodeficiency, and so what tests can we do to find out the underlying condition in the child? Right? In medicine, sometimes you have to do two things. Number one, you need to stabilize and work out what the acute problem is, treat the acute disease. But whenever you have suspicion of an underlying condition, you need to investigate that as well. And you need to start appropriate intervention accordingly. Okay, what underlying tests we can do to know what the underlying condition is? Yeah, macam cardiac, we can do echo and things like echocardiogram to rule out any congenital heart disease. For GI reflux, we can do pH study. We can do in terms of immunodeficiency, we can do the immuno profile. So we do tests to send to specifically look for the levels of the individual components of the immune system. We can measure the B cells, T cells, NK cells, and so on, just to know which component is deficient. Okay, obviously, I mean, you might not need to do everything. Depend on your history and what you find so far. Treat. You have to kind of figure out which condition you want to investigate. And if it's immunodeficiency, the history should be not only recurrent chest infection, but this child might have recurrent otitis media, recurrent sinusitis, so other deep-seated infections such as abscesses, that would suggest immunodeficiency. In cardiac, the child might be cyanotic. They might have a significant hepatomegaly, and the child might have raised JVP. So you have to figure out, based on those symptoms and signs that are available, which tests you want to perform. And I mean, if we are high in our resource capability, yes, you can do all the tests like you would do in private setting. And private setting, they do all the tests in the world, because the more tests they do, the more money they get. God, some people would argue, is that ethical or not? So this is one question to ask. Okay, now, so if I say the sputum culture came back showing organisms that are very rare, such as Proteus, Morazella cataralis, okay, Staphylococcus aureus. And just remember, Staph aureus pneumonia is common in young children, but 6-year-old is rare. Apa lagi? So Klebsiella, sputum culture positive for Klebsiella, Morazella, Proteus, all these weird organisms. Okay, is that what you would expect to see in him if he has a certain condition? Okay, paham ke soalan? Okay, so if you see these organisms in the sputum culture, what would you be thinking about?
Came from
Anyone?
gut.
Gut, not so much from gut. It's still a community-acquired infection. It's still community-acquired. Okay, so what else are you thinking about?
Is it atypical pneumonia?
Yeah, so these are all atypical organisms again. So the typical organisms are like Streptococcus, and the Haemophilus. These are all typical, but these are atypical, and most of these infections, such as the Klebsiella, there are multi-resistant organisms. Okay? So it's not the common infections that you see, and these are largely opportunistic infections as well. So they like to be opportunistic whenever, especially you have an environment. Can you hear me, all of you? Sorry, have I lost you? Boleh dengar? So whenever you have an environment that is not normal, okay, for example, in the lungs, it's not normal for the lungs to be filled up with all these sticky mucus. So whenever you have this unusual environment, you get a lot of opportunistic organisms that that would get inside the lungs or the body and cause all these infections. And because these infections are very difficult to get rid of, because whenever a child has recurrent infections, other infections, and then you give antibiotics, the antibiotics ends up killing only typical organisms, but they don't kill the atypical ones. Hence, they become resistant to normal antibiotics. And they tend to multiply because all the good bacteria, that all the normal flora pun dah tak ada, because you kill it off from all these antibiotics. So you allow these atypical organisms to multiply, to stay in, and become dormant to some extent. Okay, so the presence of these organisms might indicate a lung problem. Yeah. Okay, such as CF, for example. Okay, now let's talk about sweat tests. So sweat tests, say the results shows elevated chloride, amount of chloride in the sweat. What does that mean?
Positive cystic fibrosis.
Apa dia? Macam mana?
Positive for CF.
Yeah, so it's positive for CF. So the sweat test is very specific for CF. So if you have excessive chloride, so the sweat is too salty, then obviously that's almost 100% CF. Okay, so it's a very, very useful test. You can confirm that by checking for gene mutations, because the positive sweat test doesn't quite tell you the type of CF. CF have many different types depending on the gene that's been mutated. Okay, some types are much more severe than others. So that's why we tend to send further tests, genetic tests, to know which gene that is affected. And that's useful in terms of prognosis, in terms of identifying who would have severe symptoms, who you need to treat more aggressively, and so on. Okay, so does that kind of answer our question? This child, we think, now has CF, yeah. But the sweat test is not something that can come back very early, so you have to send it to HKL, you have to wait for a few weeks for the results to come back. So you need to, once you treat the infection on this occasion, you need to follow the child up in clinic. Now, say you're in clinic now, clinic setting. Clinic setting, you got this result of sweat test in front of you. You want to now explain to the dad, the same dad, the result of the sweat test. Okay, who wants to have a go? This is the communication aspect of this lesson. Should I just choose, Okay. Afiq lah, Afiq Syami ada. Afiq, are you here? Lari dah. Semua takut. Afiq, are you here? Tak ada. Tidur. Okay, what about Ahmad? Ahmad, do you want to have a go? Ahmad, can you hear me? Sudah, semua lari dah ni. Semua takut dah.
Doktor nak suruh consult parent macam mana?
Okay, so now with that history, remember that history just now, right? Recurrent infection, failure to thrive, the child has pneumonia, you treated the pneumonia, the child has been discharged. Before the child was discharged, you arrange sweat test, you send it to HKL. Now this is 2 or 3 weeks later. You have the sweat test result in front of you, which shows elevated chloride. Okay, you're now in clinic with the dad to explain the results of this test. Okay, faham tak? That's the scenario, So, okay, so there will be some degree of consultation, So what did, you have to prepare yourself, what things you need to inform the parents about, okay? So, yeah, so once I go, Afiq, tak ada Ahmad, pun tak ada. Who wants to have a go? Let's lari semua ni, mengelak semua ni. Okay, I'm just gonna call random people. Okay, what about Lina Khairi? Is Lina in our group? Bukan
Semua yang doktor sebut tadi semua bukan grup sini.
Oh, ya ke? Cakap lah. Okay. In that case, siapa? Sharifah Maisara? Is she in our group?
Yes.
Okay, Sharifah, why don't you have a go at explaining the results of the sweat test? Sharifah, are you here? So we've got 20 more minutes. Oh, tak ada juga. Syarifah. No? Okay lah. Izzati lah. Lambat sangat.
Okay, saya cuba.
Alright, good. Okay, come on Izzati.
Okay. Assalamualaikum Cik. Kan hari tu kami dah buat satu test ni untuk tahulah penyakit anak encik ni positif tak untuk penyakit tu bila kita buat test ni. Nama dia sweat test. So kami dah dapat keputusan tu, didapati kandungan klorid. Klorid ni sejenis garam tinggi dalam untuk kes anak encik ni. So test ni tinggi.
Tinggi.
Dan kebiasaannya
Maknanya apa tu?
Maknanya kandungan garam tinggi dalam anak encik.
Maknanya tak normal lah tu.
Tak normal. Dan kebiasaannya kalau budak-budak yang tinggi kandungan klorid ni, dia ada penyakit nama cystic fibrosis.
Apa? Cystic fibrosis?
Cystic fibrosis.
Okay, apa ya? Cystic fibrosis ni apa?
Cystic fibrosis ni dia penyakit yang melibatkan satu organ nama pankreas dalam tubuh kanak-kanak lah. Itu je ke doktor?
That's fine. Okay, teruskan. Pankreas, okay. Apa kaitan dengan paru-paru anak saya ya?
Okay, kebanyakan mostly budak yang ada penyakit cystic fibrosis ni, dia ada mutasi pada satu gene. Okay. Dan mutasi pada gene ni akan kacau dalam pengeluaran mucus, cecair dalam paru-paru. Jadi anak encik ni ada mutasi pada gene tu, so anak encik ada keluarkan banyak mucus. So sebab itulah dia mudah dapat.
Macam mana tahu ada mutasi yang tak buat lagi ke dah buat juga? Genetic test.
Kita suggest buatlah supaya tahu lebih spesifik.
Okey,
untuk tahu penyakit
maknanya penyakit ni mungkin disebabkan mutasi lah, masalah gene lah. Okey, tapi cystic fibrosis ni memang adakah dia menjadi punca kenapa anak saya kerap sangat kena jangkitan paru-paru selama ni daripada kecil? Memang sebab tu ke punca dia?
Ya, kemungkinan dia.
Tapi saya sebab tadi sebut pasal pankreas kan, saya tak berapa faham. Pankreas ni apa ya?
Pankreas ni satu organ yang berfungsi untuk release menghasilkan enzim. Enzim kan untuk mencernakan makanan.
Okey. Jadinya dia ada masalah pankreas lah.
Sebab tu anak encik mengalami tak ada pertambahan berat badan kan. Dia macam kurang.
Faham.
So dia ada masalah pada pankreas juga.
Okay. So sebab dia kurang berat badan ke sebab dia kerap sangat kena jangkitan paru-paru tu? Maaf saya bertanya sebab saya tak boleh nak faham bagaimana jangkitan yang anak saya kena teruk ni, sebab doktor hari tu dia sebut dia buat swab test ni nak tahu penyakit apa paru-paru kan. So tiba saya macam tak faham bila awak sebut pasal pankreas ni, macam maknanya apa kaitan dengan test paru-paru tu?
Saya tolong
okay, ni doktor lain lah tolong ada sebelah. Okay.
Saya cuba lah. Macam ni, swab test yang kita buat ni, dia boleh kata agak spesifik untuk sejenis penyakit yang sahabat saya sebutkan tadi, iaitu cystic fibrosis. Jadi kaitan penyakit ujian ni dengan masalah pankreas dan masalah simptom yang anak cik ada, iaitu batuk berkahak ni, sebab penyakit cystic fibrosis ni dia memberi kesan kepada beberapa organ lah. Bagi contoh, dia memberi kesan kepada paru-paru, yang mana dia menyebabkan anak encik ni menghasilkan banyak mucus, banyak kahak yang lendir yang keluar bila batuk tu. Itu antara satu. Yang kedua, ia juga memberi kesan kepada satu organ yang sahabat saya sebutkan tadi, iaitu pankreas. Pankreas ni seperti yang sahabat saya sebut, dia menghasilkan enzim untuk mencernakan makanan. Jadi bila ada masalah dari segi penghasilan enzim untuk mencerna makanan, jadi makanan yang anak encik makan, dia tidak dicerna dengan baik dan diserap. Jadi mungkin ini menyebabkan berat anak encik tidak bertambah daripada kecil. Jadi itulah
tadi doktor dia sebut pasal yang pertambahan mucus kan. Maknanya adakah disebabkan pertambahan mucus tu yang dia kerap kena jangkitan paru-paru tu?
Allah. Saya panggil doktor lain.
Sama, you're doing well so far. You can just answer what you think.
Saya rasa mungkin sebab, tapi saya tak pasti jawapan explanation tu betul ke tak. Apa saya jogi je kan. Jadi bila ada penghasilan mucus yang banyak, jadi ada pengkumpul, dia boleh menyebabkan bakteria ni berkumpul dekat kawasan penghasilan mucus tu. Jadi itu yang boleh menyebabkan jangkitan. Saya tak pasti yang tu betul explanation.
Okay. Alright. So macam mana penyakit ni boleh rawat ke? Okay, Izzati. Oh, kita buka kepada siapa lah, whoever wants to answer. Boleh rawat ke penyakit ni? Cystic fibrosis. Ada ubat ke, doktor? Doktor? Oh, doktor.
Tak tahu lah.
Oh, tak tahu. So, macam mana ni doktor? Doktor pun tak tahu. Masalah ni. Mana?
Okey, sila sabar.
Saya serahkan kepada sahabat.
Okey, pendapat saya disebabkan oleh cystic fibrosis ni sebenarnya kondisi yang melibatkan mutation dekat gene. So benda tu memang akan boleh ubah, takkan boleh ubah sampai bila-bila. Jadi jadi pendapat saya ialah benda ni tiada apa panggil treatment yang definite untuk penyakit ni. Tapi apa yang kita boleh offer, kita boleh rancang untuk anak encik ialah kita bagi supportive treatment untuk bantu dia punya pertumbuhan dari segi fizikal dan juga emosi. Dan dari segi supportive treatment ni, kita ada melibatkan banyak disiplin lah. Salah satunya kita kena review dietitian lah untuk supaya anak encik dapat nutrien dan juga zat yang mencukupi lah supaya dia dapat mencapai berat yang optimum. Dan yang kedua, kita kena refer fisioterapi sebab disebabkan anak encik ni sebenarnya dia menghasilkan lebih banyak mucus berbanding orang yang biasa. So kita bimbang takut dia tak mampu nak buang sendiri mucus tu. So sebab kita kena ada fisioterapi supaya dapat buang lebihan mucus tu. Dan juga yang ketiga, kita juga boleh apa lagi so sebenarnya penyakit anak encik ni sebenarnya dia tak boleh dirawat tapi dia boleh dikawal sehingga dewasa. InsyaAllah. Dengan syarat bila kami merancang apa-apa follow up, encik kena ikutlah follow up tersebut.
Okey, insyaAllah. Tadi doktor dah sebut dia masalah jin kan. Maknanya macam mana sebab saya sihat. Wife saya pun sihat kan. Dalam family kami tak ada pula yang pernah ada condition ni.
Dia masalah jin ni sebenarnya dia tak bergantung pada ibu bapa anak tersebut. Dia kadang-kadang macam mana dia macam jadi gitu je kot.
Datang secara random.
Dia bukan kalau parents carrier ke?
Ya kot.
Tak tahu.
Dr. Izzati betul.
Tak pernah tak jadi.
Carrier tadi doktor dah sebut carrier. Carrier ni apa pula?
Carrier ni
maknanya apa?
Salah seorang antara bapa atau ibu dia ada dia carrier jin yang mutate tu, yang ada mutasi tu.
Okey. Maknanya salah seorang kami pun ada penyakit tu.
Bukan ada tapi asymptomatic. Dia macam carrier jin tu saja. Tapi tak symptomatic.
Carrier jin tu saja. Okey, mana dia tak ada dia pembawa lah.
Ya, pembawa saja.
Okey. Maknanya saya atau wife saya pun kena test juga ke macam mana?
Untuk DN atau ke? Untuk check for mutasi tu. Mungkin
nak check sebab nak tahu saya ni pembawa ke tak kan. Maknanya adakah doktor suggest untuk saya ditest juga ke?
Mungkin.
Oh, Pak ni tak tahu.
Okay, alright. Okay lah. Okay, alright. How was that? Difficult,
Tak pernah pula konsep
I mean, CF is not very common in our country lah. But we do see so dekat HTA there are a few cases. So don't be alarmed. And it's very good to learn from because CF is as someone mentioned, it involves a lot of multidisciplines. It involves a lot of different presentations and different problems, and it's not treatable because it is a mutation. You cannot, unless in the future we have gene therapy, that's different. But in order for gene therapy to work, you have to have some degree of high index of suspicion. For example, if both families or one family member ada CF, then you can do gene therapy earlier for the offspring. Kan? But in this case, this child is already 6 years old, dah kena a lot of infections, so gene therapy won't be the way. So it is just supportive treatment. The supportive treatment including physio, weight gain by high calorie diet, and also you might need to give empirical antibiotics in the form of IV antibiotics every 2 or 3 months. So you have to electively admit the child to give antibiotics just to treat any organisms, atypical organisms that might be already in the lung. So it's a kind of maintenance kind of thing, antibiotic maintenance that you have to give. You give strong antibiotics to kill off the multi-resistant organisms. I mentioned about Klebsiella. I think Pseudomonas is very common in CF population. So you have to give anti-pseudomonal antibiotics as well. But it's not treatable. The prognosis depends pretty much on the amount of physiotherapy, the follow-ups, the weight gain that you can achieve. And some of them do survive until adulthood. But without adequate support, then they will die younger. So this is why it's very important to emphasize to parents the importance of regular follow-ups and regular interventions, supportive interventions. So although CF is not common in Malaysia, but it is one of the common topics in pediatrics that you want to know about. So as Samba mentioned and also Ali mentioned, it is a genetic problem that involves the lung and also the pancreas predominantly, because of sticky mucus. Think it that way and then you'll understand. It produces sticky mucus. So when the mucus is too sticky, it clogs up in the lungs, leading to infection. It clogs up the intestines, leading to constipation, and it clogs up the pancreas, enabling them from producing enough exocrine enzymes, and that leads to malabsorption, failure to thrive. They can also get CF liver disease. So because it clogs up the liver, it clogs up the gallbladder, it blocks the bile duct. So hence you can get jaundice as well, and a little bit of hepatomegaly. And you can get diabetes, CF-related diabetes, because the pancreas can also, the endocrine function at the pancreas can also be affected as well. So this is where the nature of CF is, it can cause all these multiple multiple organ failures to some extent. Okay, so I thought that was a quite useful case to discuss about. And my only comment for Nur Salwa tadi, to use more open questions, not closed questions. I think you start off with a lot of closed questions, yes and no type questions. Try to use more open questions. Okay, cuba cerita pasal batuk dia, cuba cerita pasal kahak dia. Okay, so that will give you much more important information. You need to ask more about failure to thrive questions. I think you covered some, but just the failure to thrive opening statement is a clue. We won't give you any information that's not necessary. So all this information in the opening statement will give you a clue of the potential diagnosis. And remember, diagnosis can either be they don't only focus on the acute diagnosis, but there might be an underlying diagnosis as well. Okay, and the communication, as usual, I think takes a lot of practice. Practice. Try practicing explaining to your parents, kat rumah, explain to them what CF is, asthma, because this is naturally how you learn to deal with the community when it comes to explaining disease, management, investigations, test results, and so on. So make use of this time at home to explain to people in a logical way. Avoid jargons. Tadi macam Izzati use things like apa tadi, mutasi lah, apalah, which okay, but you need to kind of lower down the language, so to make it a little bit more simpler for other people to understand better. Macam pancreas, you can mention pancreas, but you have to describe. Okay, pancreas is an organ dalaman yang menghasilkan enzim untuk mencerna makanan. Like I think what somebody was very good. I think this was far easier to understand, rather than assume people know what pancreas is. So sometimes we have to explain it like you explain a standard school person or child. In terms of that kind of language, you have to explain, because people won't know what pancreas is. Some people might not know what a mucus is as well. So that's all I can say. I'm afraid I need to go. Any last minute questions?
Sila.
Yeah. Sorry. Yeah.
Doktor, yang soalan doktor tadi yang parent kena check tak payah ada jawapan dia.
I think we do offer, especially if you think the parents wants more offspring, because if they are carrier, then for future offsprings, if they really want to know the status, then it's recommended to do. Especially down the line, if there's such thing as gene therapy that is ready in place that we can offer. I don't think we are ready in our context in our country, but certainly in developed countries, they're offering gene therapy early. But remember, CF can also happen sporadically. The mutation can happen sporadically, even without any carrier status between the parents. So that can occur as well. And we're seeing some of those in a few cases in Malaysia, where the mutation can occur sporadically. Okay, anything else?
Alik nak tanya apa Alik?
No, I found a journal research conducted by UM. So it stated so the research was conducted on 2004, and it is confirmed that 16 was diagnosed with cystic fibrosis, and 9 of them is from Malays. So is it occur due to interracial marriage, or it is a sporadic mutation?
I mean, we know that CF is an autosomal recessive. So if you have, if you married close cousins, then obviously, like what we call if it's consanguineous, yes, then I think the risk is higher, especially if that family tree has a lot of cases already. In terms of race predisposition, I'm not sure whether it's more common on Malays or Chinese. Certainly, it's much more common in Europe, in European population, like Caucasians, English, Americans, and that kind of, French people. That is common in that race, in those races. Southeast and certainly Asian is not common at all. But yeah, they could be some. But the problem is we don't have enough cases to actually study the demographics in Malaysia to know whether it's more common in Malays or Chinese or Indians. It's difficult to know at this stage. Okay. Any other questions? Okay. I hope you learned something. Sorry, I have to go. So if anything, you can message me in the group if you want any questions, and I'll answer when I'm a little bit more free. Okay, thank you very much, everyone.
Thank you, Doctor.
I hope you learned. Yes, I go.
Okay, Doctor.
Thank you, Doctor.
Bye. Assalamualaikum.